So if you don't remember your pathophysiology, go over it. There's a lot of videos that are really good, just bringing it back to the surface. So it's a complex syndrome, structural and functional, or both combination cardiac disorder that impairs the ability of the ventricles to fill or eject blood. Cardiac output is insufficient to meet the metabolic demand of the body. Determinants of your ventricular function are preload and afterload, contractility, stroke volume, cardiac output, and heart rate. So all of that plays into the pathophysiological changes in heart failure. Left ventricular dysfunction, which increases the end systolic volume, for diastolic volume, pulmonary congestion, decreased cardiac output, and hyperperfusion. Compensatory mechanisms that are activated, sympathetic activation, as well as the RAS system. So all of that is involved. So I thought this was a nice little schematic. So just going over everything, your ADH secretion, sympathetic secretion, we're increasing afterload, sodium and water retention, all of that kind of stuff. And then, cardiac dilation, hypertrophy, trying to combat it, and we just don't have the ability. And then we get all kinds of congestion, especially into the lungs, with right-sided heart failure. So we have systolic and diastolic function, any change in cardiac output, heart rate versus stroke volume. And remember, stroke volume is related to contractility, preload, and afterload. Your afterload is resistance, your preload is the stretch of the myocardium. All of that comes into play. So any change in that process is going to affect your cardiac output. Systolic, basically the ventricles are not able to generate stroke volume. Included causes, contractility, MI, cardiomyopathy. If it's systolic dysfunction, we basically label that one the heart failure with reduced EF. So then if we have diastolic dysfunction, I think more issues with the stiff ventricles and not being able to fill appropriately. So then think fibrotic, non-compliant, there's an increase in the afterload, hypertension, left ventricular hypertrophy, valve issues, stiff valve, something like that. A lot of times we are going to label this the heart failure with preserved EF. There's two classification tables. So we have the ACC and the AHA, which is listed for you here, classifying it as AD, stages A through D. And then we have the New York Heart Association heart failure, and that's classification of 1 through 4. I put them kind of side by side so that you could see exactly how they correlate with each other. Stage A is high risk of development of heart, no underlying structural cardiac disease yet, and there's no correlation with the New York heart. And then that's lifestyle modifications, ACE for your diabetics, ARBs if they're intolerant. Stage B, structural heart disease, but asymptomatic, same here. D and stage 4 are refractory heart failure, symptoms at rest. So that's how we classify it. So here we have reduced EF heart failure. So it is, acronym is that, and then we have preserved heart failure. So that, and then we have this mid-range, which is, 40 to 49%. And kind of, there's some other things that you could take a look at, such as the BNP and the pro-BNP, and you need to have at least one structural issue. Reduced EF is, EF less than 40, and usually lots of signs and symptoms that come with that. And we do treat them differently, so your pharmacological interventions are different. All right, so there is a vast array of patient presentations, and it all really comes down to EF. Remember your signs and symptoms, primary care facility. It is going to be chronic heart failure management. So risk factors, there are so many. This is just a handful, but basically anything that can interrupt and cause problems with filling, pumping, anything like that. Pharmacologic management of heart failure is basically diuretics, ACE inhibitors, beta blockers, cardiac glycosides. Also, we do phosphodiesterase inhibitors, vasodilators, and dobutamine and dopamine. So you need to understand how these are working in the heart failure. At a minimum, patients should be on an ACE or an ARB. They need to be on a beta blocker. Spirolactolone is another good one that we use in heart failure management. Other meds include hydralazine, isosorbide. We're going to talk about that a little bit later. DIG we're going to talk about too. So goals of treatment for chronic CHF. So alleviate symptoms, pharmacotherapeutics, lifestyle modifications, exercise, health maintenance. Delay progression, BP and hypertensive meds, weight loss and obese, treatment of dyslipidemia, and glycemic control in DM. DM plays a big part in chronic heart failure. You know how important it is then to make sure that you're managing the blood sugars. And reduce mortality. This is where your evidence-based medicine comes in. So there are some that have been proven to impact survival, and they are listed here for you. So here's PRESERVE. So largely governed by the management associated conditions, there is limited direct evidence, not much evidence to specifically support some drug regimen. So your general principles: control pulmonary congestion, peripheral edema with diuretics, treat your systolic hypertension, prevent rapid heart rates, and then coronary revascularization in patients with CHD and ischemic. So here is kind of a flow chart of what we're going to be using: mineralocorticoid receptor antagonist, and that's your spironolactone. Diuretics, obviously loop diuretics are what we talk about most. Beta blockers, they are really big on the angina signs or symptoms, not necessarily in. And then CCBs may be beneficial, but you can see here evidence is lacking. And ACE and ARBs used cautiously unless renal disease. Now this is for preserved EF. So reduce, we're looking at improvement of symptoms and survival, attenuating or reversing, remodeling, geometry of the function of the left ventricle. All of these used in therapy combination: diuretic, ACE, beta blocker, nitrates, hydralazine. So when we're talking about the diuretics, so the loop diuretics are working down here. Your potassium sparing diuretics, which is spironolactone, is working over here, remember? And your spironolactone is a mineralocorticoid, and remember that it has those endocrine side effects. The loop diuretics, basically sodium chloride loss, and with that follows water, and we're going to get into loop diuretics next. So loop diuretic class information: furosemide, bumetanide, and torsemide. Lowest dose should be titrated upward until there's a therapeutic effect achieved or an adverse effect limits further titration. In patients with persistent signs of fluid overload, diuretics are usually necessary. So inhibit chloride and sodium reabsorption in the loop of Henle, proximal and distal tubule. So it basically shuts it off from being taken up. Dosage has to be appropriate for loop diuretics. If it's not, no diuresis occurs at a lower recommended dose. So these would be ones that you definitely want to follow dose recommendations, because if you don't, you may not get any diuresis, right? So they're very important when we're talking about effect. What it's going to do is reduce sodium chloride reabsorption in the thick ascending loop of Henle. Then we have sodium potassium pumps sodium out, potassium in, and that's going to create a low intracellular sodium concentration. Potassium crosses through the K channels and allows into the lumen to be more positively charged, allows reabsorption of sodium, calcium, and mag. And remember, you have those basically slow channels, and that's what this is down here. When we're talking about loop diuretic, that is why we get the hypokalemic metabolic acidosis. Potassium crosses through those K channels. Loss of sodium and water, and then increased calcium loss as well, and you can see here. So I thought this was a really good schematic. Metabolism of this is liver minimally, and none CYP450 that were known. Excretion is obviously a lot in the urine because that's its mechanism, that's where it's acting, and not so much biofeces. And you can see it has a very short half-life when we're talking about Lasix. It basically has a 6-hour kind of window. Dosing of this: furosemide versus Bumex versus torsemide, all things created equal. You could say Lasix of 40 milligrams, and this goes on to that potency thing, equals Bumex of 1 milligram, equals torsemide 20 milligrams. So you can see there's a lot more Lasix that's needed. So Lasix is the least potent of these diuretic class. So just keep that in mind as we're talking. Torsemide is roughly a 100% bioavailability once you take first pass. All right, so that's huge as well. Lasix, on the other hand, is 50% bioavailable. So now you understand why you have to give so much more Lasix, because you actually have to overcome 50% bioavailability. So that's what's interesting in that. Baseline monitoring for Lasix, you obviously need to know your kidney function, liver function as well, because it does matter. And you may need to have the dosing different if there's any hepatic issues, heart failure, or renal failure. And then serum bicarb and electrolytes frequently early in treatment, and then periodically CBC with platelet. So there is no number that's associated with renal dosing. It's just contraindicated if they're anuric. All right. So if they're not able to make urine, obviously contraindicated. Cirrhosis, ascites. So pretty advanced hepatic issues, then caution is advised. So renal dosing is important, and there's 3 factors that may change dosing. Is there a reduction in renal blood flow for some reason? So that would be that heart failure. Changes the delivery of the drug to the kidney, so then you kind of have to overcome that to get the activity. Activation of the RAS system, so sympathetic nervous system, so the SANS. So that basically enhances sodium reabsorption in the kidney. So it's going to change your dynamics of action. And then the third thing is if you have a reduced GFR, that leads to diminished secretion of the drug, the proximal tubule. Okay, so those things would all alter and the way that it's getting to the site of action for the Lasix. Lasix will increase BUN and creatinine, and that's why you follow it. And then it's going to decrease potassium, and that's why you're going to be checking for this metabolic alkalosis, and then in hypotension. So it's going to increase the risk of hypotension. And those are the things that you're going to monitor. So pregnancy, you can see there, caution advised, and consider lactation alternatives. Oh, and you can see here that it actually does decrease milk production. Makes sense, right? Because you're dehydrating, you're diuresing. So common reactions are obviously urinary frequency, dizziness, weakness, muscle cramps related to dehydration, nausea, vomiting, anorexia. Electrolytes there, low mag, calcium, and potassium. We walked through that mechanism. It will elevate glucose and uric acids related to the effects in the tubules. Tinnitus. Remember that this is really big, especially for giving IV version of Lasix. We learned that as a nurse. It can be permanent or transient, and it's, they think, related to a co-transporter in the sodium potassium chloride that is also found in the ear, and that's why it's related to the higher doses or IV. So this one is usually IV or very high doses. Major side effects are severe hypokalemia, severe electrolyte disturbances, metabolic alkalosis related to the potassium issues, hypovolemia, severe hypotension, and then you can see that we're affecting the blood lines as well. There is a sulfa cross sensitivity, so just be aware of that with Lasix. All of that put into a nice slide for you. So we already talked about ACE inhibitors in the previous unit, so I just wanted to, when we're talking about heart failure treatment, this is key, and this is why I included it in here. So yes, we talked about side effects and all that kind of stuff. I'm not going to go through that all again, but when we're talking about evidence-based medicine, ACE inhibitors have shown to decrease the morbidity and mortality associated with heart failure. So very important that they're on board. Same mechanism of action, so we are inhibiting Ang1 to Ang2, and that is basically going to allow for all of these side effects to be minimized. Beta blockers, we did not talk entirely about these, so I do want to go in these a little bit in depth so that regardless of where you're using them in the cardiac system, all the side effects are the same. Beta blocker withdrawal we have to be concerned with, so all of that, and we're going to go over that next. So remember, first, second, third generations, non-selective versus selective, or whatever we're using this for, we're going to see it again when we get to the coronary syndromes. So beta blockers decrease sympathetic stimulation by basically blocking adrenergic stimulation. So beta 1 receptors are on the myocardium, so you are blocking that and you are decreasing myocardial contractility, you're decreasing heart rate, output, work, and oxygen consumption. So here is again that beta blocker, beta adrenergic receptor on the cell site, myocardial or other tissue. It is epinephrine and norepinephrine, which is the neurotransmitter that is released. Decreases renin release from the glomerulus, less outflow from the kidneys, and less water retention. Heart failure mechanism is aimed at reducing the effect of sympathetic stimulation, reducing heart rate, myocardial energy demands, remodeling, arrhythmia promotion, and our renin-aldosterone angiotensin system. So that is what we're looking at in heart failure. So we're attacking a lot of the mechanisms that we talked about with the preload, afterload, and then activating the RAS system as well. So the side effects. So the big ones that we're talking about with beta blockers are beta blocker overdose. This can be intentional or not. And then withdrawal. So that's the big one. So you cannot just withdraw beta blocker therapy. There's some other side effects that are associated with elevated potassium levels. There's some sexual dysfunction that comes with it. There is fatigue, and also depression can be associated with beta blocker therapy. So those are kind of the ones that are not related to sympathetic blockade. So the overdose, basically, you are blocking catecholamines, and that can create a system, which is obviously going to be a severe bradycardia, and that can result in some issues. Beta blocker withdrawal. So this is the big thing. So beta blocker withdrawal is associated with increased mortality and morbidity. So it's a big one, and boards do go after that. What happens is that there's an increased sympathetic tone, most likely related to upregulation of the receptors from that sympathetic blockade that happens continuously with beta blocker therapy. So what it does ultimately is increases the responsiveness to the catecholamines that are circulating, and then you withdraw the beta blocker blockade, and you're going to have all these circulating catecholamines, and basically you'll have a rush of catecholamines, and that can create some ischemic symptoms, as well as precipitate an MI in anybody that has known cardiac disease, increased ischemia, and possible MI. So that's what's going to happen if you have beta blocker withdrawal. So the common side effects are obviously hypotension, bradycardia, fatigue we talked about, dizziness, cold extremities. They can have some dyspnea with it as well. Baseline monitoring. So you need to know your kidney function at baseline, as well as your BP and heart rate, and then intermittently through therapy. Renal dosing, be cautious with creatinine clearance under 35. There's not really nothing delineated related to hepatic dosing. Pregnancy and breastfeeding. So you're going to avoid in late pregnancy, second and third trimester, and consider alternative for breastfeeding. Beers list, obviously we utilize these a lot in our elderly population, but you know what the side effects are, so obviously it could precipitate falls, so you have to be very careful. Next up is DIG, is cardiac glycoside. It is useful in heart failure due to systolic function and certain SV tachyarrhythmias. So those are the two clinical situations that DIG is indicated for use. There is a meta-analysis that came out that DIG in patients with heart failure is associated with a higher risk of all-cause mortality. These are difficult drugs to manage. So it inhibits sodium-potassium adipase. So inhibition of the sodium-potassium adipase pump in the myocardial cells results in a transient increase of intracellular sodium and promotes calcium influx via the sodium-calcium exchange pump, which leads to increased contractility. Here is the fact that you're blocking the sodium-potassium adipase. So very important that dosing, so DIG has a very narrow therapeutic. You got to pull labs, you got to watch, very high yield drug. Lots of monitoring goes in with it, as well as making sure that they don't go toxic. Low doses, older, 70, impaired renal function, low lean body mass. Body mass has a lot to do with DIG dosing. And if it's low body weight, we want, about 50% less dose. We want on that lower end of the dosing. If they're lean to normal body weight, which is that 70 kilograms, then you can go in the lower range of the normal. You may need higher doses based on obesity, but they still want you to be on the normal range. Like, you're not supposed to increase it. It's still within the normal range, but you would expect that you're going to use the higher end of the normal range. All right. You have to monitor plasma levels, and toxicity may occur with lower levels, especially if there is hypokalemia that is comorbid with it. Hypomagnesium or hypothyroidism coexist. So these are things that would put you in to have easy toxicity. There's no hepatic dosing issues with this. It's all related to renal. But then you need to have, between 10 and 50 creatinine clearance before they recommend reduced dosing. And then you're going to be reducing dosing by 50 to 75% if this is present. So great reductions. Baseline parameters. So creatinine, electrolytes, heart rate at baseline, then periodically you may want to get a TSH just to make sure there's no thyroid issues. Heart rate and rhythm should be monitored along with periodic ECGs as well, according to UpToDate. And that's to assess desired effects as well as signs of toxicity. You will want to do also the electrolytes. So we talked about potassium, definitely, mag, definitely, and calcium. And then there may be issues if there's comorbid, concomitant diuretics because of all of the changes to your electrolytes, so be very careful there too as well. DIG serum concentrations are monitored at least 6 to 8 hours after that last dose, regardless of route, and that would be your first one. And that would be considered trough, would be 6 to 8 hours after last dose. It should be obtained within 5 to 7 days after initiation, and 5 to 7 days is steady state, and then anytime dose changes. So when do you get these serum drug levels? So anytime there is a compliance question, anytime renal function has changed, you are suspecting DIG toxicity, there is a add-on of amiodarone, verapamil, or quinidine. We talked about thyroid issues, so thyroid diagnosis. So your serious reactions are severe bradycardia, ventricular arrhythmias, AV block, thrombocytopenia, delirium, hallucinations, and intestinal ischemia, hemorrhagic intestinal necrosis. Therapeutic range for DIG is 0.5 to 0.9. So with your DIG toxicity, remember that yellow hue to vision would be something that you would see. The delirium, the hallucinations, also nausea, vomiting, lethargy, all kinds of heart blocks which present themselves, or some ventricular issues. So that's going to be your toxicity. Interestingly enough, it is okay in pregnancy and breastfeeding. There's no risk of teratogenicity or fetal harm that has been shown in evidence. So chronic coronary syndrome, so stable ischemic heart disease is basically low risk, unstable angina, lifestyle modification, smoking cessation, weight management, physical activity, lipid control, and blood pressure control. Clinical syndrome is considered unstable if any of these things occur. So the chest pain occurs at rest, is new in onset, is severe, or it's increasing with severity and requiring less provocation in patients with previous angina. So we all know what acute coronary syndromes are. Obviously, you are not treating these in the primary care setting. you're calling 911. Imbalance between myocardial O2 supply and demand. We are going to focus on decreasing workload by decreasing preload and afterload, and we are increasing oxygenation by dilating the coronary arteries. So muscle is not adequately perfused either by atherosclerosis or vasospasm. We are trying to increase oxygenation and decrease workload and equalize supply and demand. You can have multiple variations of your clinical presentation, normal to typical and atypical, versus that low risk unstable angina. So management of ischemic coronary heart disease is basically all of these. All right. Antiplatelet therapy, we're talking about aspirin here, is where you would be. Up to date was 75 to 325 milligrams, and that's pretty much what you see across the board, depending on what other comorbidities are present. But basically, if there's a diagnosis of ischemic coronary heart disease, then they should be on antiplatelet medicine. Some may be on dual antiplatelet, all depends what the pathology is. And then it's a stepwise addition of beta blockers, calcium channel, and long-acting nitrates. So we already talked about beta blockers, we already talked about calcium channel, so tonight we're going to just look at long-acting nitrates and short-acting, because that's the class that we haven't covered yet. The three classes of anti-anginals are basically: 1, beta blockers should be on, number 2, calcium channel, and then nitrates. So those are the three main anti-anginal drugs. Beta blockers are first line. CCBs can be used as monotherapy or add-on to beta blocker. And then long-acting can be add-on or monotherapy. Primary prevention versus secondary prevention, and this is where you're going to get your variances in doses. So that low dose of aspirin to prevent the first MI versus to prevent subsequent MI. So beta blockers in this mechanism block beta receptors, inhibit sympathetic effects of epinephrine and norepinephrine, basically going to decrease cardiac workload, improve oxygenation, decrease angina signs, and improve exercise tolerance, which is what we're trying to do here. Do not use this if there is the vasospasm form, which is Prinz metals, right? So beta blockers should not be used for them. Calcium channel blockers, they actually want you to choose the long-acting ones. And then also the non-dihydropyridine calcium channel blockers are recommended, and your non-dihydropyramine, your DILT, and your VRAP. So those are actually the preferred for ischemic coronary heart disease. If you need the dihydropyridines, then it would be amlodipine or felodipine. You avoid the short acting unless with a beta blocker. All right, so this needs to be with beta blocker therapy, not by themselves. The longer acting, the non-dihydropyridine calcium channel blockers are able to be used by monotherapy. Causes coronary and peripheral vasodilation. So coronary and peripheral vasodilation, and reduces contractility. Nitrates. So we're going to spend a little bit of time here. So nitrates can be used as mono or add-in therapy. They are going to improve exercise tolerance, time to onset of angina, and ST segment depression during exercise testing. So there's a clear reduction of ischemia related to nitrates. So nitrates stimulate cGAMP production, resulting in vascular smooth muscle relaxation. So you're going to get it basically everywhere. So venous, arterial, and then also coronary artery. What they basically say that the demand, the decreased myocardial O2 demand is from is by dilation systemically. So systemic dilation, not necessarily the coronary artery dilation. So it's more related to decreasing the preload. We are decreasing left ventricular and diastolic pressure. It also reduces wall stress, and this all leads to decreased O2 demand. What's interesting too is that nitrates actually have antithrombotic and antiplatelet effects. They're not really sure if there's really a big clinical, but transdermal nitrates, so that would be our transdermal nitro paste, does inhibit platelet aggregation. So that would be an example of its effect. So sublingual nitro, acute angina is the only indication for the sublingual. Transdermal or PO is for chronic management. So you have transdermal nitroglycerin, which is for chronic angina, and isosorbide mononitrate or dinitrate. They can be used as monotherapy as an alternative to beta blockers or in combination therapy. What's interesting is if you do use it in combination therapy, it does improve and have better effects of both. All right, so basically better effect when used with combination. So the issue with long-term nitrates is this induction of nitrate tolerance. So this is high yield. This is something that you need to know about. So they believe nitrate tolerance is related to impaired conversion of nitric oxide, which ultimately leads down. So we have decreased nitrous oxide, and this is where your nitrates are working. There's going to be reduced availability of nitric oxide. And then it's actually due to the vasodilation going to activate the RAS system, which is going to lead to vasoconstriction, nervous system. So that's going to activate because we have overall vasodilation, and that's going to create a tolerance. So we do try to prevent that, and on the next slide we'll talk about that. But that's the big issue with long-term nitrate. Isosorbide mononitrate is the one that you're going to see in practice. We do not use the dinitrate one. Mononitrate is Imdur. These drugs are relatively well utilized when we're talking about there's really no renal issues or hepatic issues. There's no dosing changes or anything like that, so you don't have to worry about that. What's interesting here, though, is that they do need that period of time. Nitrate-free periods must be provided, and basically 8 to 10 hours is what they were seeing that you should be nitrate-free. So the way that our dosing is with that is that it's recommended for the IR to be BID, and that they recommend it 7 hours apart, and they recommend it at 8 a.m. and 3 p.m., something like that. So 7 hours apart. The extended release is only once daily, and then you take that once in the morning. Side effects, there's a lot, all right, but a lot of them are related to some cardiovascular. The big ones, though, are going to be headache and dizziness related to vasodilation. May have some CNS depression with it, so be careful there. But the main things are phosphodiesterase 5 inhibitors. So these are your erectile dysfunction meds, which are obviously vasodilators too. So you do not combine them with Imdur, or you could result in severe hypotension if combined. And then the other thing is the tolerance. So those are the two big things that you need to know about the long-acting nitrates, short-acting nitrates. There's a new drug on the block. About 2006, this came out, ranelazine, a new therapy for angina. It is an anti-anginal agent. Mechanism of action is unknown. Inhibits late sodium current, reducing sodium-induced calcium overload. Improves ventricular diastolic tension and oxygen consumption. May be useful, beneficent in conjunction with or substitute for beta blockers. It does prolong QTc interval in a dose-dependent manner and is contraindicated in combination use with potent inhibitors of the CYP3A4 pathway. And then here's the big ones on that. All right, not going to talk too much about it. Usually these guys are put on by the specialists.